this lecture, we will discuss aversion therapy. Aversion therapy is the treatment that directly decelerates a maladaptive behavior by associating it with an unpleasant stimulus. With physically aversive consequences, an unpleasant event is administered immediately after the client performs the deceleration target behavior. So, as a reminder, deceleration target behavior decreases a particular maladaptive behavior. And acceleration target behavior is adaptive behavior that is increased in therapy. In aversion therapy, an adverse stimulus is introduced while the client is engaging in the deceleration target behavior, and it is terminated as soon as the client stops performing the behavior. The objective is for the client to associate performing the target behavior with the aversive stimulus so that performing the behavior becomes aversive. This is the same process that accounts for the development of common avoidance behaviors. For example, a person may get airsick when a plane encounters turbulence. Subsequently, the individual may avoid traveling by plane, which is associated with the unpleasantness of airsickness. Aversion therapy primarily has been used to treat two classes of maladaptive behaviors: substance abuse and paraphilias, which are sexually deviant behaviors such as exhibitionism and pedophilia. I have a whole series of paraphilic disorders if you wish to review them. Now, let's review the basic procedures. Maladaptive behaviors can be paired with any stimulus that the client finds aversive, that is, unpleasant, distasteful, or painful. Shock and nausea-producing drugs are the most frequently used physically aversive stimuli. Occasionally, noxious odors as well as hot air and smoke to decelerate cigarette smoking are employed. Psychologically aversive stimuli include feelings of humiliation and unpleasant thoughts. The adverse stimulus may depend on the target behavior. Adverse stimulus is associated with the target behavior in one of three ways. Ideally, the association is created as the client is, first, actually engaging in the target behavior. Because this is not always possible or efficient, the client can be, 2, symbolically exposed to the target behavior, as by reviewing pictures of the target behavior or listening to a verbal description of it, or by 3, imagining performing the target behavior. Aversion therapy has been used to decelerate cigarette smoking. One technique called rapid smoking has clients first smoke at the rate of the puff every 6 seconds. Second, inhale normally. And third, continue smoking rapidly until they cannot tolerate it anymore. In some cases, the aversion created by rapid smoking can have long-lasting effects in decreasing cigarette smoking. Although such results have not been obtained consistently, because rapid smoking can cause temporary cardiovascular stress, it is used infrequently. In summary, in aversion therapy, an unpleasant or painful stimulus is introduced while the client is engaging in the deceleration target behavior. The client comes to associate a target behavior with the unpleasant stimulus, most often shock or nausea. The association can occur while the client is performing the behavior, is symbolically exposed to the behavior, or is imagining performing the behavior. Aversion therapy is used primarily to treat substance abuse and paraphilias. Because the effects of aversion therapy may be temporary, booster treatments may be necessary to increase its durability. Aversive procedures have come under scrutiny regarding ethical violations. In fact, aversive procedures constitute a small portion of behavior therapy techniques and are used infrequently. When used, a cost-benefit analysis is performed for each case. In my next lecture, we will review token economies. What is a token economy? And how to combine reinforcement and punishment.